This PowerPoint was developed using slides copyrighted by Elsevier and images off of Google. My use of them in this presentation is legally allowable as fair use for educational purposes. Nursing 150, Chapter 46, Cerebral Dysfunction. We're going to start with a discussion on increased intracranial pressure. So the brain is well protected but vulnerable to pressure that can accumulate within the cranium. Early signs and symptoms of increased intracranial pressure may be subtle and include headache, nausea, vomiting, and increased blood pressure. As the pressure increases, signs and symptoms become more pronounced and level of consciousness deteriorates. Seizures and fixed pupils may occur. So here's our little review of cranial anatomy. So for altered states of consciousness, consciousness implies awareness. So alertness is our arousal, awake state, and cognition is our ability to process stimuli and produce responses. Altered consciousness can fall along a spectrum, and alterations in consciousness can be anywhere from brief to forever. A coma is unconsciousness, where the patient cannot be aroused. So changes in levels of consciousness are the earliest indicator of changes in neurological status. This can be difficult to determine because of a child's developmental level and a child whom you've never met before. So parents can be very helpful during this assessment. You can ask the parent, does he seem normal to you? Is he normally this sleepy at this time of day? Is this a normal speech pattern for your child? In descending order, different levels of consciousness include full consciousness, confusion, which involves impaired decision making, disorientation to time and place, lethargy, which includes sluggish speech, obtunded, which is extremely lethargic and near comatose, and comatose, unconscious. Motor activity, reflexes, and vital signs are not parallel to the depth of level of consciousness or the presence of a comatose state. So remember that. They don't correlate to one another. We need to assess each individually. So there are a couple different ways to do coma assessment. Preliminarily, in cases of emergencies, we use the mnemonic AVPU, alert, voice, pain, unresponsive. And that really is the first category in the Glasgow Coma Score. So the Glasgow Coma Score is a score of eye activity, verbal activity, and motor responses. And these are scored and totaled, and we can see that here. So the lowest possible score where someone's totally unresponsive is a 3, and that usually indicates some sort of either brain death or induced paralysis. And then less than an 8 can be considered comatose. And then a best response in a normal, healthy person is a 15. This is the adult Glasgow Coma Score. There are little modifications based on age. For example, if this was an infant under best verbal response, they wouldn't tell us the time, place, and person, but it would say something like interacts and coos appropriately, or for motor response, that they are moving independently, putting their hands in their mouth, trafficking objects with their eyes, for example. But throughout the ages, this scoring remains the same. So a decrease in the Glasgow Coma score less than 8 indicates severe deterioration. You can always remember less than 8 intubate, because once someone gets down to an 8 or below, we know that they're going to have difficulty protecting their airway. And that's why at that point, intubation for artificial ventilation is highly recommended. Brain death is the complete cessation of all brain function. And for someone to be brain dead, their condition needs to be as such, but also irreversible. So our assessment parameters for increased intracranial pressure is going to involve our level of consciousness, our Glasgow Coma score, pupil reaction, vital signs, and we should be doing a neuro assessment depending on the condition, anywhere from every 15 minutes to every 4 hours for all of our patients. So in a stable patient without neuro issues, every 4 hours is adequate for an inpatient child. For a child who's in neuro ICU with a brain injury, it's definitely going to be every 15. Clinical manifestations of increased ICP in infants include irritability and poor feeding, high-pitched cry, difficult to console, fontanelles tense and bulging, cranial sutures separated, okay, because remember there's a buildup of pressure in that area, eyes with the dark circles underneath, and distended scalp veins. Increased intracranial pressure, clinical manifestations in children, say school-aged children, includes headache, very forceful projectile vomiting, seizures, drowsiness, lethargy, decreased physical activity, and inability to follow simple commands. These are all danger signs. Late signs of increasing ICP, signs that it has gotten very severe, include bradycardia, decreased responses to motor commands, decreased response to painful stimuli, alterations in pupil size and reactivity, extension or flexion posturing, and I have a picture of that I'll be showing here in a second, decreased consciousness or coma. So this is posturing. We'll see this a lot of times with increased intracranial pressure with a neuro injury. And decorticate and decerebrate are the main two. So decorticate involves problems with the C-spine or the cerebral hemisphere. So I always remember that decorticate is not as bad as decerebrate, because decerebrate is a brainstem problem. And you can kind of use this little alphabetical mnemonic to help you. So decorticate has more C's, so the arms and the feet are moving in like C's, and it's a cortex problem, whereas the decerebrate is extension, where they're moving outward like E's, and that is a brainstem problem. So decerebrate, E's, extension, it's the end for them. Not a very good sign. There aren't very many patients that we see doing this type of decerebrate extension posturing that are going to make a full recovery. At this point, their brain injury is quite advanced. So some documentation programs don't use the terms decorticate and decerebrate. I think Meditech used flexion and extension, but this is what they're talking about. It's the same thing. So as far as other levels of consciousness, obtundation, if someone's obtunded, they may appear unconscious, but they will arouse with stimulation, even if it's just temporarily. So this is the person that's kind of passed out and they're not really able to answer questions very well. But if you yell their name in their ear, they'll at least look at you, and they might say a few words, even if they're inappropriate. Coma is no motor or verbal response to noxious stimuli. So even with pain, like a sternal chest rub, they're not going to flinch. A persistent vegetative state is a permanent loss of function in the cerebral cortex from which there is no recovery. Here I have an example of pupils. The one on the left is constricted and the one on the right is fixed and dilated. So this is consistent with extremely high increased intracranial pressure. It's actually consistent with herniation, which is fatal. We'll talk a little more about that in a moment here. So as far as diagnostics, when someone has increased ICP, they may do an EEG, which is assessing response to brainwave response to auditory and visual stimuli. They may do a lumbar puncture if they're trying to diagnose meningitis or some sort of infectious neurological process that could be found and identified in the spinal fluid. But if someone has these advanced signs of increased ICP, a lumbar puncture is contraindicated and it can't be done then. Some of the imaging we may do for our neurological cases, simple x-rays can rule out skull fractures and other cervical spine fractures. But it's not the end all for that by any means. Most of the times we're going to be getting a CT of the head, a CT of the neck. CT of the neck will show C-spine injury better than X-ray will. And then if we're trying to see even more brain, then the CAT scan has shown MRI will show even more of the brain. So for respiratory management in the comatose child, airway management is going to be the primary concern. Once someone's brain has been hypoxic for more than 4 minutes, they begin to experience irreversible brain damage. And that is not a long time. When you think about some of the downtime some of our patients have when they enter a rest, or if they have a seizure that they're not able to breathe through, or near drownings, that 4 minutes can go by pretty quickly. CO2 retention causes vasodilation and increased cerebral blood flow and increased ICP. So for this reason, we're going to want to have good ventilation, and we're going to want to check our blood gases to verify that on the ABG. Cough and gag reflexes may be decreased, and there is a risk of aspiration of secretions increased during coma. However, if there's an increased ICP, we're going to want to be very careful and judicious with how and when we suction so as not to irritate and raise the ICP further. So there is such a thing as ICP monitoring. There's a monitor for intracranial pressure. The indications for needing to do this would be a GCS of less than 8, traumatic brain injury seen on a CT scan. So not all brain injuries have abnormal CT scans. We'll talk about minor brain injuries a little later, but this would be traumatic brain injury with abnormal CT scan. Deteriorating neurologic condition, or a clinical judgment regarding the patient's appearance and response may warrant it. So There are a few different types of ICP monitors. There's the intraventricular catheter, which is illustrated on the left here, where the catheter is going down through the brain into the ventricle. There's the subarachnoid bolt, also called the Richmond screw, and that goes down only past the dura. It does not go down as deep through the brain into the ventricles. So this, if you remember your anatomy review, is going to depend on where's the injury, what's the source of the pressure buildup, what area of the brain are we needing to monitor. Because if the source of the pressure is outside here and the screw is adequate, then that's going to be the preferred choice. Epidural sensor, so if the pressure is mainly a spinal cord issue, they could monitor it via an epidural catheter. And then there's also a non-invasive anterior fontanelle pressure monitor cup that we can apply to neonates. Care for the patient with increased ICP. For patient positioning, we're going to avoid neck vein compression. So we will want to keep their neck straight. We want to keep the head of the bed elevated 30 degrees so that gravity can work on our side. And then we want to minimize manual repositioning. So putting these patients on the air mattress. A lot of ICUs have the alternating pressure mattresses where the air circulates and the pressure changes, and it decreases the needs for manual turning with pressure ulcer prevention. And so that is definitely indicated for these patients. Avoiding activities that may increase ICP, so cautious avoidance of suctioning, eliminating and minimizing environmental noise, keeping a dark, quiet environment, and that may involve limiting visitors. So visitors need to be quiet and not stimulating. I'm going to give IV fluids. If they are unable to eat for more than a few days, we may need to go to parenteral nutrition, TPN. Definitely want to avoid overhydrating. So careful eyes and nose and daily weights, because overhydrating is going to lead to more brain edema. We may need to place a G-tube if we're not going to do TPN. That may be an option. And then assessment and monitoring for aspiration and aspiration prevention. So you'll remember from our endocrine lecture last week, we discussed SIADH and DI, and these can accompany nervous system conditions. So what happens is there's hypothalamic dysfunction that causes altered pituitary hormone secretion. So we may need to tailor our fluid replacement and our electrolyte balancing and our medications to respond to either situation. General medications that we're going to give with increased ICP, antibiotics if it's an infectious process. We can give IV mannitol or 3% saline, which are both hypertonic solutions to osmotically shift water off of the cerebral tissues. We could give corticosteroids IV to address inflammation and edema. Give sedatives or anti-epileptics as needed to keep the patient calm and also not seizing. Sedation or amnesics, anxiety medications keep the patient calm and relaxed, especially if they're intubated, very important. Paralytic agents, if they're intubated, again, we are going to want to sedate them It's very terrifying to be paralyzed but aware of the fact that you're paralyzed. So never administer a paralytic agent without administering some form of sedation first. Use of phenobarbital to induce or maintain a coma for rest and healing is used in very severe cases. Pain assessment in the comatose child requires careful nursing observation. Signs of pain are going to be increased agitation and rigidity, increased heart rate, respiratory rate, blood pressure, decreased oxygen saturation. So anytime there's an alteration in vital signs, we're going to think, could this be pain doing this? And we're going to need to be vigilant then in our monitoring, because as you may remember from our pain lesson, changes in vital signs related to pain are less apparent in children than they are in adults. So adults are more prone to vital sign changes because of pain. In kids, that usually happens later once they're in severe pain. So it requires a careful nursing assessment to try and pick up on that earlier. We don't want their pain level to be high, because the pain level being high is going to further increase their intracranial pressure. So for pain management in the comatose child, opioids might be used. There is some disagreement on this. We can definitely use fentanyl. Fentanyl is a preferred drug of choice, as is Versed, because Versed is a sedative that has amnestic properties. So we don't really want these kids to remember being terrified on the vent. So this is going to be a traumatic experience for them. The amnestic properties of the Versed are an extra benefit. And vecuronium is the one paralytic that's routinely used for children who are ventilated. We could give acetaminophen with codeine if it's a more mild case and they're able to take PO. We want to ensure regular administration and adequate dosage to keep the pain levels down, and comfort measures like a quiet, dimly lit environment. Other care management for increased ICP, monitoring their temperature. So these patients, depending on what trauma they've gone through or what mechanism of injury or pathophysiology of their disease process, they may be hypothermic or they may be hyperthermic, and using a thermoregulator to do that. Usually this is going to involve, in the ICU environment, we can place a Foley catheter that has a temperature sensor in it, called a temperature Foley or a thermistor Foley, and hook it up to a box so it gives a continuous reading of the patient's core temp. And then we can apply a thermoregulator blanket called a bear hugger that blows either cool or warm air, and manually adjust that to the need. So elimination, again, Foley, stool incontinence care, pericare, positioning, gentle range of motion if they can tolerate it, controlling stimulation, and then gradually as they're healing, they will be regaining consciousness, and throughout the process, emotional support for the family. There are 3 major causes of brain damage in childhood, and they are falls, car accidents, and bicycle or sports-related head injuries. Head injuries could take on various forms, from less severe to more severe: concussions, skull fractures, brain contusions, hematomas, and diffuse injuries. And here is an example of our 2 different types of hematomas, the epidural hematoma and the subdural hematoma. We are going to start by talking about concussions. So a concussion is an alteration in neurologic or cognitive function with or without loss of consciousness. So loss of consciousness is no longer required to diagnose a concussion. So what happens with a concussion is there's an alteration in function. So it could be something as simple as, I was dazed. I saw stars for a few minutes. I got hit in the head and I zoned out, and it took me a minute to come back. This is transient, so this is temporary and reversible. They come back pretty quickly. It's often followed by amnesia of the event. So the details of the injury are fuzzy, and they may be confused about what time it is or where they are now. Parents are no longer instructed to wake the child through the night. So some of you may remember that back in the day they would say, oh, wake your kid up every hour to assess their orientation. We don't have parents do that at home anymore. We will teach parents the danger signs of elevated ICP, and so if a child has elevated ICP, that's a sign that it's more than a concussion, that there's some other more traumatic type of head injury going on that we missed or that has developed. So we would tell them the danger signs are decreased level of consciousness while awake, worsening headache, vision changes, and nausea or vomiting, and that if they have any of those, to go to the emergency room for a repeat CAT scan. As far as contusions and lacerations, contusion is visible bruising. So this could be contusion on the scalp that we can see on the outside, or this could be a brain contusion on the inside that can be seen on a CAT scan. Laceration is a tearing of tissue. So this could be a cut on the head or a tearing of tissue on the inside that's seen on CAT scan. Head wounds, scalp wounds bleed a lot. So oftentimes there is a lot of blood. Then it may seem disproportionate to the area of laceration. It could be a small cut that produced a lot. Coup and contra coup brain injuries. Coup is the bruise at the point of impact, and contra coup is the bruise at the opposite point of impact. So we have an image here to help you appreciate if you hit your head on the wall, you're going to have the coup injury on the front, but then the brain is going to ricochet back onto itself, and that is the contra coup injury. Skull fractures. So because of skeletal flexibility, immature skulls can withstand a greater impact before they fracture. To produce a skull fracture in an infant, the force must be extreme. Any infant with a skull fracture is suspicious for abuse. Most infants who fall off the couch will not have a skull fracture. That is highly suspect. Different types of skull fractures are linear, depressed, comminuted, basilar, open, and they could be fixed or growing. Basilar is a fracture in the bottom of the base of the brain, and when that happens, often cerebrospinal fluid escapes and watery discharge from the nose or ears. Anytime you see that following a head injury, think that's possibly cerebrospinal fluid. One easy check you can do for that is if there is watery discharge from the nose or the ears after a head injury, you can put it on a tissue or on some gauze and look to see what it looks like. Because snot and tears and sweat, they all look uniform in color on a tissue. But if it is cerebrospinal fluid, you will see a variation in color that looks like a halo pattern. It'll look like a circle with a halo around the outside, and that's the presence of glucose, and that definitely indicates that it's cerebrospinal fluid. The other way you can confirm that is with a a urine dipstick or a finger stick test strip to confirm for the presence of glucose. If you can confirm the presence of glucose, it's cerebrospinal fluid. Other signs of a basilar skull fracture besides the watery discharge from the nose and ears are battle sign, which is bruising behind the ear, and raccoon eyes. Complications of head trauma include epidural hemorrhage or epidural hematoma, which is bleeding between the skull and the dura. And the source of that is arterial, so it has a more rapid onset. The subdural hemorrhage or subdural hematoma is bleeding between the dura and the arachnoid membrane. The source of that is venous, and it may have a slower onset. So these are the patients who hit their head, they seem okay, and then hours or a day later are deteriorating. That is a cardinal presentation of a subdural. Cerebral edema is associated with traumatic brain injury, and it leads to increased ICP with the threat of herniation, which anytime the brain herniates out of its cranial space, that's fatal. Diagnostic evaluation of head trauma. For our initial assessment, we're going to get a detailed history, and then we're going to be simultaneously assessing our priorities, our airway, breathing, circulation, ABCs. We're going to evaluate for signs of shock, do a neuro exam, level of consciousness assessment with Glasgow Coma Score, and assessment of vital signs, and then we'll do some imaging, primarily CAT scan, or perhaps if we need more MRI. Behavioral assessment, that would be more useful for a child whose GCS is maybe a 14 or 15, but the parent's saying, oh, they're just not acting right, they're not themselves. So documenting what the parent is reporting. There are some neurological post-traumatic syndromes. Post-concussive syndrome are behavioral concussion symptoms that last up to a year after injury. So these can include short-term memory interruptions, difficulty concentrating, changes in mood, and this can last up to a year after the injury. Post-traumatic seizures without a previous seizure history, so someone could develop seizures from their new head injury. Structural complications such as hydrocephalus, so maybe an obstruction in the flow of cerebrospinal fluid, a buildup of spinal fluid in the ventricles. Post-traumatic brain injury syndromes can last several days to months, and they can have long-term developmental effects in children. So for therapeutic management of head trauma, we're going to do immediate C-spine mobilization on scene. We're prioritizing airway as part of the C-spine ABCs. So when we open our airway, part of opening our airway and ensuring its patency is immobilizing the C-spine, either with your hands or your knees or a collar, and then doing a jaw thrust to maintain alignment. We don't do head tilt, chin lift in trauma. If this is severe head injury, LOC for several minutes, loss of consciousness or altered level of consciousness for several minutes, new or prolonged seizures, they're going to be kept in the hospital. If someone's injury was bad enough to be kept in the hospital, they're going to be NPO at first, at least for the first 24 hours. This is to cut down on vomiting if their ICP increases. And this is also to prevent aspiration if emergency surgery is needed. Then they will have already been NPO. The reason why patients are NPO prior to surgery is because when they have their anesthesia induction and they intubate them, they're at risk of vomiting their stomach contents and aspirating into their airway. So if we keep a patient NPO in anticipation of this person might need an ICP monitor installed, or this person might need a hematoma evacuated. If they are having a bleed into their space, then they can go right to surgery. That won't have been an issue. They'll have already been NPO. So for surgery, hemorrhage or hematoma evacuation as needed, or an ICP monitor placement as needed. Near drowning is a major cause of accidental death in children. It can occur with even a small quantity of water, even as small as a pail of water. A near drowning means that the child survived for at least 20 hours after the submersion. If someone survives for 24 or more hours after the submersion, then we wouldn't say they drowned. We would say they drowned. We wouldn't say they drowned. We would say that they died from complications related to near drowning. Pathophysiology of drowning, the hypoxia is due to pulmonary edema, the presence of fluid in the lungs. Atelectasis happens and airway spasm. They develop an aspiration pneumonia, and they frequently have hypothermia because of the large surface area that was exposed to cold water. So they've been exposed to cold water not only on their outer body, but now it's in them as well. Emergency resuscitative efforts, CPR, is done on scene. Management is based on the degree of cerebral insult. So if we have minimal downtime, we're going to be very aggressive, all measures. If we've had extensive downtime before resuscitation was attempted, then our approach is going to be a little bit different. If we are able to resuscitate, these patients are definitely going to be hospitalized for observation, and they're going to need treatment for aspiration pneumonia. They're going to need antibiotics. The best predictor of prognosis is their submersion time. So remember, the anoxic brain injury takes 4 minutes. So taking it from there, and then how long were they submerged. Helping parents cope with feelings of guilt is going to be a huge part of this. And as always, we're going to teach all of our patients how to prevent submersion injuries. Intracranial infections. So intracranial infections always have an inflammatory component, and this can affect the meninges, the brain, or the spinal cord. Lab studies are required always to identify the causative agent and determine course of treatment. Meningitis is an acute inflammation of the meninges and cerebral spinal fluid. It's had a decreased incidence since the introduction of the HIB, the Haemophilus influenzae vaccine, in 1990. That was a primary agent before. It can still be caused by various other agents. Bacterial pneumonia is the most dangerous, and the bacterial pneumonias, the greatest offenders are strep, Neisseria, and that we have group B strep, strep pneumoniae, Neisseria, staph, and E. coli. So meningitis is transmitted by nasal droplet secretions. So these patients need placed in droplet isolation. And oftentimes this is an extension of another bacterial infection, such as a sinus infection that traveled. And the organisms then spread to and through the CSF. And this can, once this is in the CSF, this can spread by droplet pretty quickly among children. Large numbers have gotten it at once through contact at school. There is a seasonal variation. We seem to see flares of it in the late winter and early spring. So for diagnosis of meningitis, we have Kernig and Brudzinski signs, which assess the extent of a stiff neck. So there's general complaints of a stiff neck. And then, so anytime a child complains of stiff neck, we'll do these assessments. And if they're positive, that's highly suspicious for meningitis, and they should have a lumbar puncture to test their CSF. So the Kernig sign, the patient supine, the hip is flexed 90 degrees, and the knee cannot be fully extended. The patient resists it and complains of neck pain with doing so. With Brudzinski sign, passive flexion of the neck causes flexion of both legs and thighs and report of pain. Lumbar puncture is the definitive test for meningitis. Normal CSF appears clear. On the micro report, there may be RBCs in the sample from the puncture site. So a tiny bit of blood may get into the sample from the actual puncturing of the skin. With viral meningitis, the WBC will be mildly elevated. With bacterial meningitis, the CSF will appear cloudy, the WBCs will be very elevated, and there will also be increased protein and decreased glucose. So therapeutic management of meningitis includes droplet isolation, antibiotics, maintaining hydration, maintaining ventilation as needed. Some of these kids, it progresses to a point where they need respiratory support. Keeping the ICP down and managing that. If that goes up, managing shock and control of seizures or temperature. These kids are at high risk for seizures and fevers. For drugs, we're going to give anti-inflammatory steroids like Decadron, antibiotics, supportive drugs as needed. Prognosis depends on the organism and promptness of treatment. So bacterial is always worse, more dangerous than viral. And promptness of treatment. How long have they been having these symptoms? Have they been allowed to deteriorate at home? And these kids generally will experience some sequelae or lasting effects. The best prevention of bacterial meningitis is through vaccination. So we have the Hib, the Haemophilus influenzae B, and now the pneumococcal vaccine Prevnar, because as strep pneumoniae is a common agent. We're going to keep a quiet care environment with minimal stimuli. We're going to keep the head of the bed elevated to keep our intracranial pressure down. Side lying position may help after lumbar puncture. A lot of times after lumbar puncture, they can get that spinal headache, and having them lay on their side reduces that rather than having them lay on their back. Pain assessment, and a lot of times the treatment depends on the symptoms. Emotional support for the family. Encephalitis is an inflammatory process of the central nervous system with altered function of brain and spinal cord. It's caused by a variety of causative organisms. Usually it's invasion of the nervous system by a virus after some other viral infection. The biggest vector reservoir in the United States are mosquitoes and ticks. Clinical manifestations of encephalitis are malaise, fever, headache and dizziness, stiff neck, nausea, vomiting, ataxia, which is altered gait, and speech difficulties. Signs that the encephalitis is severe include high fever, disorientation, obtunded level of consciousness, seizures, muscle spasms, spasticity, coma, cranial nerve involvement with eye palsies, and paralysis. These patients need hospitalized for observation and supportive treatment. We want to identify and treat the cause. We're going to culture the cerebrospinal fluid, and we're going to culture the blood as well. And we're going to do testing for Lyme disease and Rocky Mountain spotted fever and Zika virus. And if this is a tick-borne encephalitis, the treatment is IV doxycycline antibiotic. ICP monitoring may be required, and they're going to need extensive follow-up care with reevaluation and rehab. In very young children, this creates the possibility of neurologic disability for the rest of their life. Rabies is an acute infection of the central nervous system. The virus is transmitted by the saliva of infected animals. In particular, skunks, raccoons, and bats are the most common carriers, but it can be transmitted to all mammals. The virus multiplies in muscles, and infection is fatal if untreated. So symptoms include tingling around the bite site, fever, headache, muscle aches, loss of appetite, nausea, and fatigue. So if there is a bite, we want to do thorough cleansing of the wound. And then if we know that the animal was rabid, or we suspect that the animal was rabid, we want to immunize our patient with the human rabies immune globulin as soon as possible. So back in the day, this used to be a large volume, many cc's, that divided up in many syringes. And originally, it needed injected subcutaneously in the abdomen, so you needed multiple needles to the abdomen. Then it was IM, so you needed multiple IMs all over. The volume of injection has decreased dramatically, so that now it can be divided up into just a couple shots. And now we only have to give 4 doses. We used to have to give a lot more. So we really have enhanced the supply of rabies immune globulin. Reye syndrome. Reye syndrome is a disorder defined as toxic encephalopathy associated with liver involvement. It's characterized by a fever, profoundly impaired consciousness, and impaired liver function. It occurs more often in children than in adults. The cause is not well understood, but it seems to follow common viral illnesses such as influenza or chickenpox. A potential association has been found between the use of aspirin for fever and the development of Reye syndrome. So for this reason, aspirin is no longer recommended to be used for children to control fever. Seizure disorders. Seizure disorders are caused by excessive and disorderly neuronal discharges in the brain. The type of seizure depends on the site of origin. This is the most common neurologic dysfunction in children, very widespread, and it's often a symptom of an underlying disease process. So more specifically, epilepsy is defined as 2 or more unprovoked seizures caused by a variety of different pathologic processes in the brain. Optimal treatment and prognosis of epilepsy requires an accurate diagnosis and determination of cause. So some of the different causes of seizures are acute head trauma or meningitis, prior brain injury such as encephalitis or stroke. Cryptogenic means there's no clear cause. Idiopathic means it's likely genetic. And then there's also pseudo-seizures, which are not actually true neuronal discharges in the brain, but are a psychosomatic manifestation. So seizures can be classified as partial or generalized. So partial is also called petit mal or absence. And that's a local onset and involves a relatively small location on the brain. It's characterized by zoning out and or eye twitching, and for this reason, because it is so vague, it's often overlooked for some time. So we're going to watch a video here of a child having one of these.
Dylan, you okay, honey? Darling.
So he's just kind of staring, and his one eye is kind of droopy, and he's not really able to move or respond. You can see how easy it would be to overlook a seizure in a kid like this. Okay, there, he just snapped out of it. See that? So, yeah, that can be very insidious, actually. And then we have our generalized grand mal seizures, which involve both hemispheres, and it's not localized. And this is more severe. And we'll watch a video of a young man having one of these in case you've never seen one before. His little Yorkie dog is worried about him. And this can be worse. But this is just one example. So for therapeutic management of seizure disorders, the goal is to control seizures or reduce the frequency and severity. Ideally, discovery and correction of the cause. There are a couple different options for management, usually through drug therapy, and a lot of the drugs require monitoring of blood levels to assure proper dosage. Another option is ketogenic diet. So this is kind of interesting. There's a diet called the ketogenic diet for seizures, where it's extremely low carb and extremely high fat and protein. And it's very hard to follow. For this reason, there are not a lot of children who are able to comply with it. But it's found that if you can comply with it, it really works. And we're not 100% sure why. But it's difficult. It's like, okay, for breakfast you get 6 slices of bacon and a stick of butter. It's a lot. It's very high fat, very high protein, and it's not something that appeals to a lot of children either. So just for those reasons, logistically and realistically, it doesn't happen for a lot of kids. Some patients have success with a vagus nerve stimulator implant, so they found that by stimulating the vagus nerve on some individuals, they're able to prevent their seizures from occurring. And then if there's a structural reason for why they're having seizures, it could potentially be something operable that they could fix during surgery. Status epilepticus is a flare of uncontrolled seizures, and typically something is happening where the medication dosage needs increased. And medication dosages are going to need adjusted regularly as the child grows. Prognosis for seizure disorders depends first of all on compliance with treatment, and second of all on the body's response to treatments. So if a child is seizure free for 2 years, they can gradually decrease the med dosages in an attempt to get them off of meds completely. So that is possible. However, for a lot of patients, it does require long-term management. A lot of these kids will be on meds for life. We can identify and avoid triggering factors: stress, bright lights, strobe lights, video games, stimulants. The treatment goal really is just to have them live as normal of a life as possible. Febrile seizures are transient, meaning it will go away, disorder of childhood that involves having a seizure due to a fever. It's fairly common, affecting 2 to 5% of children, and it usually occurs between ages 6 months and 3 years of age. It rarely happens in kids older than 5 years old, and it's most common in boys, twice as frequent. Why some kids have a seizure with their fever We're not really sure why. It usually happens with viruses more so than with a bacterial infection. We're going to talk next about some cranial deformities, and we're going to start by reviewing the normal schedule of suture and fontanelle closure. So by 8 weeks of age, the posterior fontanelle closes. By 6 months of age, the fibrous suture lines interlocking of serrated edges occurs. By 18 months of age, the anterior fontanelle closes. After 12 years of age, sutures are unable to be separated by increased ICP. So at 6 months old, they started to interlock, and after 12 years of age, they're fully fused. So hydrocephalus is an enlargement of the cranium caused by excessive production or inadequate absorption of CSF. And the pathophysiology is one of two types, communicating or non-communicating. So communicating is there is impaired absorption of CSF within the subarachnoid space. And this is not related to an obstruction. So it is free-flowing. It's just not being absorbed adequately for some reason. The obstructive kind, where there's an obstruction somewhere through the ventricular system, is non-communicating, meaning it can't get through. Most hydrocephalus are the result of neural tube defects. So again, the importance of women of childbearing age to take folic acid daily to prevent neural tube defects. Hydrocephalus is usually apparent in early infancy, especially, that brain is the most mobile then, so it's going to appear, the skull, I should say, is quite mobile then, not the brain, the skull, and so it's going to appear quite enlarged. Other causes that could happen later: cancer, infections, trauma. The presence of hydrocephalus is often associated with a myelomeningocele or spina bifida sac. Treatment is most often surgical. If there's a myelomeningocele present, surgically repairing that, and then also the placement of a shunt, a ventriculoperitoneal shunt for CSF drainage. So this is actually a passageway that they place from the ventricles where the fluid is built up down into the peritoneal abdominal space to drain excess fluid. We'll treat any complications that have occurred because of this condition and assess development problems related to the effects, motor involvement. So these shunts can either be totally closed, or they can have a port to the outside of the child's head so that they can be adjusted based on the daily need. And we're going to watch a video demonstrating that.
Feel me touching right here, okay, and then you're just going to feel me place this right here, okay, all right, and I'm going to see what number you're at.
So she's measuring his pressure today.
Kind of a weird angle. It's pretty cool. You're doing great, baby. I'm just doing some touching, okay?
It's okay.
Okay, you're at a 3, and now we're going to take the magnet.
Okay.
She's adjusting it with a magnet through his skin.
What was that wound?
That was a magnet. So I can reprogram your noggin. See, it's at a 4, Mom?
That's cool.
Okay, and double check. It's at a 4. This little thing's a little. All right, that's it. It's just a touching.
I'm getting a worse headache right now.
So the most common complication with shunt placement is a shunt infection. Cerebrospinal fluid is full of glucose, and bacteria loves to grow with glucose. The period of greatest risk for infection is 1 to 2 months after shunt placement. Shunts need replaced regularly as kids grow, either to accommodate their growth for one thing, but also because a lot of times new obstructions develop along it. And so regular replacements, or they call them shunt revisions, are done. And this is when they have the greatest risk of getting a CSF infection from the shunt. So the infection can manifest itself as just a wound infection at the surgical site on their head, meningitis, most common, bacterial endocarditis if that bacteria travels to the heart, peritonitis, so the infection down in the peritoneal area at the distal end of the shunt, or septicemia, having the bacteria get into the bloodstream and turning into a bloodstream infection. Treatment for shunt infections is massive dose antibiotics and or temporary shunt removal. And there are a lot of kids that are constantly needing shunt revisions and constantly getting shunt infections. So that really is a challenge to treatment with these kids.